I'd like to express my gratitude to Dr. Liu, Dr. Zhang, and of course, Dr. Nian, and of course, Bachman Hospitals for collaborating with us to hold these AI workshops. And welcome distinguished guests to this event. Today, we will explore how artificial intelligence, AI, is revolutionizing the radiology by enhancing the diagnostic precisions and transforming clinical practices. AI integrations into radiology is not just a technological advancement, but a paradigm shift that promises to improve the patient care and operational efficiency. So I'd like to share Canon directive in AI with activity and how AI is integrated into the present radiology market. So how important is AI in radiology? AI is crucial in radiology for the ability to analyze complex imaging data and, of course, giving you the high accuracy diagnostics. Thus, it really enhances the radiologist, the doctor capabilities, allowing for earlier disease detections and, of course, more personalized patient care. And AI integrations into radiology is not just a technological advancement, as I mentioned, it's going to promise to improve the patient care and operational efficiency. So what is the current state of AI in radiology? There is multiple technology being used. One, of course, is the deep learning, and it is utilized for image recognitions as well as analysis. And there will be also a deep convolution neural networks, or CNN, which is effective in processing the visual data, which is crucial for image-based diagnostic. And the last is NLP, or we call it the natural language processing. It helps in interpreting the radiology reports and extract relevant information in a database. So it actually helps to look at the reports from the radiology perspective view. And to simplify, I will use the common term AI for easy explanation. So AI adaptations in radiology has been rapidly increasing. So by 2020, about 30% of department has actually included AI. The integrations actually involve of AI into the existing workflow to help in diagnostic, to help in streamline operation, workflow, and to optimize the efficiency in terms of manpower. So we can see here, there is 33% increase from the previous year, as in 2023 October, of FDA approved AI-enabled medical devices. And out of this 33% increment, 77% actually come from radiology. So radiology actually dominates and lead the field in AI device approval. And of course, Canon Medical is among the top few companies that registered for the FDA approved in USA. So I'd like to share with you our Canon AI branding that we use deep learning, which we call Altivity. So specialists across the world has already welcomed our growing profile of deep learning reconstruction technology into the daily practices. And what are these? It's break into three pillars or three main functions. One, we talk about AI in terms of image quality. It will enhance clinical confidence with high quality images without radiation dose penalty, without long time scanning as such for MRI, and without tedious workflow. And next is the AI report, where the algorithm used will produce fast and accurate result with a more personalized approach to the patients. And last, which is the most important to enhance in the AI radiology, is the workflow. It will be totally AI driven and workflow that actually optimize the resource department, reduce the manpower required for your daily radiology routine. So actually, AI reduces the workload of the doctor by automating those difficult tasks like reporting generations as well as image analysis. And this will allow the doctor to be able to focus on more complex cases and overall workflow efficiency improvement. So radiology is the key area for innovations, and already the AI application is available in clinical use, including image optimizations like smart workflow automations and also automatic stroke detections with CT or MR, and also automatic detection of the pulmonary aneurysm, aortic dissection in terms of emergency situation where time is very crucial. So this is the whole lineup from generating of the images from our AI-equipped diagnostic equipment to categorization of the reports and streamline workflow with our AI algorithms, and lastly, providing the AI insight to the report within minutes, giving you fast and accurate to assist in decision-making, especially for crucial cases like stroke or aorta dissections. So let's take a look about how we can integrate the AI into our Canon imaging modalities from CT, from DSA, ultrasound, and MRI. Let's start with CT. We are providing more meaningful AI into the CT in terms of workflow, in terms of image quality, and how AI can improve the image quality to super resolutions without extra cost in terms of hardware, and automated report that streamline the workflow for emergency cases that are very time critical and crucial. And all to end from starting scanning to processing to report is done with our AI workflow. So Canon AI in CT is to improve the operator experience. We talk about the two camera there, where we can do a single touch of positioning to the protocol selections, which is a new instinct workflow that is a totally new interface. By selecting and drag the protocol, the AI will determine the scanning range automatically with our 3D scanogram using our silver filter. So this is the pilot scan for scanogram of the CT after a one-touch positioning. We are scanning in a 3D with a silver filter, which is very low dose, equivalent to a 2D scanogram or even a chest X-ray. And the AI will able to identify major organs from the patient anatomy and automatically set the planning range and the size and FOV for that particular patients. And a simple click and touch of a button, you are ready to scan. So with that, we implement an integrated AI positioning and planning to the system that reduce the workflow step with the manual planning up to 40% and up to 97% accuracy using our auto landmark detections, which we call ALD. And we have been the pioneer in terms of the deep learning reconstructions, which we used in 2018, we introduced Advanced Intelligence Clear IQ Engine, or we call ACE, was developed for our Aquilion Precision Ultra High Resolution CT scanner. And the following year in 2019, ACE is migrated to all other systems in our Canon CT lineup, including the 1632 slice CT. Now, we are in 2022, we further improved the deep learning reconstruction with a super resolution cardiac reconstruction that are able to use the data from a precision CT of 0.25 mm slice thickness. And last year, we introduced in RSNA, which is available commercially in 2024, we introduced the PIC 1024, which is the high resolution reconstructions using precision data of algorithm that we have used for training the data. So we use our equivalent precision, which is our super high resolution CT of 0.25 mm as the raw data to train the image data coming from our 640 slice CT. With that, we are able to achieve a spatial resolution improvement of using the data of 0.25 mm of the ultra high resolution CT to give you AI super resolution image quality for your. So this is just an example of a cardiac scan CTA using a super resolution AI reconstructions. And the patient heartbeat is 74 beat with 1024 metrics. We scan in 0.24 seconds. One heartbeat giving you a super resolution, a very good image quality from proximal to the distal. I'm sure Dr. John Ho will talk about more data with his clinical experience. And next, we talk about the AI spectra reconstruction or the AI dual energy reconstructions. Where we are using a full spectral transformations by projecting from one energy of high energy to low energy and low energy to high energy. This is using an AI algorithm that we were able to transform KV switching data of high energy and low energy to full energy for dual energy analysis. Next, we will talk about the AI integration to the angio or DSA. This is a global first or commercially where we actually put a real-time AI into DSA angio systems. Previously, we are talking about AI reconstruction image where we are talking about AI post-processing the image to improve the image quality. And now, in Canon, we introduced the Alphinix Evolve Editions, where we use a real-time AI for real-time fluoroscopy images. You will be able to improve the radiation dose. You will be able to improve the workflow. So we use the training algorithms of the training data using the AI or CNN or neural network, and then we actually put it into the actual system for clinical use. So when you are using your angio or DSA for fluoroscopy, the AI will kick in to do a real-time processing to give you a high quality fluoroscopy image without the penalty of radiation dose. So I'm going to show here two images. So you can see two images, and one is coming from CINI or DSA, and the other one is coming from our AI processed fluoroscopy. So can you tell which one will come from fluoroscopy? So actually the one on the right-hand side is AI processed fluoroscopy and is of a lower radiation dose using a copper filter compared to a CINI acquisition on the left-hand side that is acquired with a higher radiations. So you can see with this real-time AI noise reduction and multi-frequency processing, Alphinix Evolve Editions can deliver a 2x higher contrast to noise ratio as compared to the conventional imaging. So what does that imply? It means we are able to give you deeper anatomical perceptions, also more confidence in challenging situations, and you don't have to use very high radiation dose for complex procedure. You can also minimize your contrast media use for the patients, And we are able to achieve up to 30% of radiations reduction with our pilot site experience in New Zealand. Next, we talk about how AI is using to stabilize the stent, or we call it the AI DDS, the Dynamic Device Stabilizer. So with that, we are able to eliminate, to remove the appearance of the motions and enhance the stent visibility, especially for talking about complex procedure. So this is a very robust AI algorithm that established through our deep learning technology, and it works for fluoroscopy, for better workflow, and most of all, to do the radiation dose reductions. So whatever situation with your stent deployment, AI stent stabilizer can be used to stabilize in the central field of view to give you more confidence, and this is very useful for precise stenting procedures. So what does that mean? This is a conventional approach of a stent deployment. Normally, you will have to do a fluoroscopy, and to do a stent deployment, you have to go to a digital angiography or DSA for increasing the dose to look at the image quality with the stent enhanced, and followed by another fluoroscopy, and followed by another digital DSA for a second lesion, and finally do a fluoroscopy for confirmations. But with our AI technology, now you can do everything with our fluoroscopy, because with the AI real-time fluoroscopy, we are giving you good contrast to noise ratio, and you don't have to switch between different scanning mode for your deployment, and especially when we are talking about complex procedure. So with this, we will be able to shorten the procedure time, improve the patient outcome. As well, we can reduce the radiation dose for the patients and the scattering radiation dose for the doctor as well. So definitely a better technology and smoother workflow and less dose. So let's take a look at ultrasound. We are using a new level of sharpness with our AI algorithms. We are using, we call it the third harmonic imaging, or 3HI, where this AI process the technology using a deep learning to extract the third harmonic imaging from a wideband signal and giving you a high resolution low cutlets, able to give you more sharpness as well and clear image, especially in the near field. So this is a conventional image as compared to our third harmonic imaging with our AI. Definitely less cluttered, less noise in the near field images. And we also talk about the clarity images compared to the conventional. So this is on the right hand side, much clearer and significant reduction of the noise using a third harmonic, and where AI are used to process the image in real time. Again, a closer look with superiority of the image quality and sharpness using our third harmonic imaging with deep learning technology. This is just an introduction of the And next, I will touch on our last modality for AI will be our MRI. So we are looking at AI innovation that uses the technology that to make a whole new level of pathway. And we are talking about AI noise reduction as well for the image quality. So with that, we are able to have more higher productivities. And next is we will enhance efficient diagnosis with the AI artifact reductions. And last but not least, we improve experience from operators, from user and patients with our AI workflow. We all know that MRI always have long time scanning in order to get a minimum acceptable image quality or SNR. Let's take a look at our Canon workflow solutions. Begin with Tian, our Vantage in 2022. We have integrated a smart workflow like a work pad. We are able to get ready before setting the patient in the room. And the link up, we can set up the protocol easily. And our Canon camera is used as a ceiling for auto detection of the landmark for easy centering and positionings. And with the view of the patient's smart monitor, we are able to do a one-touch positioning to the center of the MRI to start our scanning. And we come with auto scan assist, which I'll explain a little bit later, that we are able to improve the workflow. So with that, we are able to improve the patient experience in terms of MRI scanning that used to be traditional and conventional, taking a longer time. So this is our auto scan assist, where we use AI for planning for different parts of the body, from neuro, for cardiac, liver, knee, or even full spine and prostate. So these are all AI-based anatomical detections, and this planning will reduce significant workflow in terms of manual clicking and depending on the level of the experience of the technician or radiographer. So let's take a look at a cardiac scan where we are able to do it with our AI cardiac and ensure volume of interest. A pilot scan of 20 seconds is being done. It's a set of axial images. And with that, the images are processed by the systems to look at the algorithm. And the anatomical automatically are being detected. And we all know cardiac MR has a lot of planning to do manually in terms of short axis, long axis, 4-chamber or 2-chamber view. And this can be done easily by just the software. Up to 14 planes can be planned automatically. And a single click of the buttons, you can start scanning cardiac with no tedious planning and prolonged. We require an experienced technician for doing so. And next, we'll talk about the AI reconstructions. We talk about ACE, where AI image reconstructions or deep learning reconstruction improve the images in CT. We also have ACE in MRI, where we do the AI reconstructions for 1.5T as well as 3T. So ACE will be able to reduce the noise by significantly detecting the noise from the signal and reduce it, filtering it away with the AI algorithms. So it actually gives you a result in SNR without the require of prolonged MRI scanning. So this is an original image on the left-hand side with a single acquisition of 1 minute and 45 seconds. And this is a 1024 by 1024 matrix. On the right-hand side, we use ACE, our AI deep learning reconstruction, to remove the noise. So AI will recognize the noise from the signal and do a processing. And with that, you will have a very high SNR, very good image quality without the penalty of long scanning time. So it can also use in enhanced resolutions, as well as you are be used to enhance the anatomical detail. So this is an example of a single scan at 1 minute and 45 seconds on the left-hand side. You can see a significant amount of noise causing a very low image quality. And the center image is scanned with 17 minutes. That is an average of 10 scans to achieve a very high SNR images. On the right-hand side, we use the single scan acquisition image, which is scanned in 1 minute and 45 seconds. And this AI will identify the noise and remove the noise from the signal. So with that, we are able to improve the signal to noise ratio. And you can see that this acquisition of 1 minute and 45 seconds is comparable to 17 minutes. So with AI image reconstructions, we are now able to improve the scanning time or shorten the scanning time and thus improving the patient's experience. This is a scan where we are using speeder or compressed speeder, or some of you know it as compressed sensing. We can do a compressed speeder 3D scan and improve the scan times from 10 minutes on the left-hand side, which is conventional scan of 10 minutes, 1.1 mm by 1 mm imprint resolution with 1 mm slice thickness. And if you look at the compressed speeder, now we are able to improve the scan time to less than 4 minutes with the same scanning requirement. And at the same time, we can combine our AI reconstructions with the compressed speeder on the right-hand side to give you further improvement of the image quality. So with that, we are able to pair compressed speeder or compressed spanning sequence with our AI reconstructions. This is just an example of an entire brain protocol where the total scan time usually with the conventional scanning will take 15 minutes, that including DWI, a flare, T2 weighted, T1 weighted or T2 star, and even the MRA 3D. And now with the AI reconstructions, we can significantly cut down the time by half, up to 53%, and using the AI to improve the SNR, signal to noise ratio, by removing the noise from the signal. At the same time, with AI reconstructions, we can also improve or compensate for the SNR loss due to the thinner slice. So you can see on the top row of the images is a conventional scan, which is 4 mm at 2 minutes and a half. We can improve the scanning protocol to a 1.8 mm slice thickness and imprint resolution of 0.8 by 0.8 for this T2 weighted. And we can reconstruct it with an AI algorithm to remove the signal, to remove the noise from the signal. So with that, we are able to improve and cover the signal to noise ratio loss due to thin slice with our AICE or ACE. At the same time, we can also improve the signal to noise ratio with very high resolution imagings. So you can see here, this is a 0.15 by 0.15 imprint resolution with a 2 mm slice thickness. And then we are able to compensate for signal to noise ratio that is lost in high resolution with our AIC. Significant improvement in the image quality, and gray-white matter is more clear. And last year, we also improved the AI reconstructions with our peak. This is AI high resolutions images reconstructions that are able to generate high imprint resolution images. So allow you to triple the matrix dimension, both in plane, that is 9 times higher. You will be able to decrease the image noise. You will be able to increase the image sharpness. Also, of course, it can help you to reduce your scanning time. So this is peak, is our next evolution forward in MR, where we peak, we will be able to increase the matrix size, remove the noise, deliver more sharper anatomical images to take MRI imaging to the next level. So you can see how the noise and high resolution images as compared to the image before without our peak is significantly improved, and the reconstruction matrix is now 3 times to 1002 by 1002. So here is a knee imaging example demonstrating the reconstructed matrix over 1500 using our peak. And you can see there's a significant improvement in the clarity in terms of the spatial resolution as well as the signal to noise ratio. So what can we do with this peak? The original scan on the left-hand side with a 320 matrix will require almost 3 minutes. So we are able to reduce a scan time of 1 minute to 1 minute and a half, and we reduce the matrix to 256 by 256 in terms of scanning matrix. And next, we apply peak, which is our AI high-resolution reconstruction to upsize the matrix to 960 by 960. So what you get is a shorter time scan as compared to a conventional scan. But on the right-hand side is a high-resolution image matrix that are using AI high-resolution algorithm to process to give you the high-quality image without the penalty of time. Next, we talk about IMC. As we all know, sometimes when we are talking about patients, especially with chronic diseases, they are unable to stay still during the MRI scan. Those spastic movements will cause artifacts. And now, with our iterative motion corrections that we include with our AI algorithm for detecting the motions, we are now using AI to remove the artifacts. So this is a IMC flare, which is comparing to the conventional flare on the left-hand side with some sporadic movement of the patients is being removed using our AI algorithm. And further, we can improve the signal to noise again with our AI reconstructions. So with two-stage AI from artifact reduction as well as image noise reductions, we will further improve the image quality by reducing the noise. So this is a sagittal flare, scanning time of the same, but you can see a significant removal of the artifacts compared to the conventional, as well as there's an enhancement of the signal to noise ratio by reducing the noise. Next, I'll talk about our real-world benefit with our automation platforms. Automation platforms is an AI platforms where we will be able to use to generate AI insight for critical time decisions cases. On the top, you will see the conventional workflow where we are talking about imaging in terms of a radiology department. And after scanning, whether it's CT or MR, you will have to send the images to process by the technicians or the radiographer before you can actually analyze it or work in terms of neuroperfusions to prepare the result for the doctors to report. So by doing these manual steps, this will take up to 30 minutes or even 45 minutes. With our automation platforms, or we call it the AI automation platform below, is totally a zero-click process. After scanning by the CT or the MR, the images sent to the AI server will automatically process and categorize the images. And the AI will also automatically analyze and detect any abnormality and prioritize and alert on the result to the doctors. So the insight and the reports will be able to send automatically to the stroke care team if we are talking about a CT stroke or MR stroke to give a better, shorter times where the result to give faster decisions for time critical situations. So our automation platform is an AI platforms that will be scalable as compared to other commercial products out there. We introduced in 2022 the stroke CT package. And 2023, we also introduced the chest pain package for pulmonary analyzations or aorta dissections. And we also have the incidental pulmonary MRIs in 2023. And this year, we also have introduced the stroke MR package to detect stroke. So let's break down the CT stroke applications that we are able to cover in non-contrast CT or contrast CT. With the non-contrast, we are able to automatically identify for any intracranial hemorrhage and automatically do the expect scoring for decisions for the patients that are coming in with the CT stroke situations. And we also have the contrast CT contrast scan where we are able to identify automatically the large vessel occlusion or even the CT brain perfusions data that can be produced in about 5 to 6 minutes as compared to the traditional 30 minutes. Next is our MR stroke, where we will be able to scan with MR diffusions, brain perfusions, and also able to identify the diffusion-perfusion mismatch. And with the DWI and flare measurements, we can even do an onset time estimation for TPA administration for that particular patients. And for chest pain applications, especially in the emergency department, we are able to identify and treat the patient quickly with the positive finding that sometimes PE is very difficult to identify with the normal CT scan. And automatically this will be traced and highlighted with our automation platforms. As well, this also can be a triage applications to accurately detect any aortic dissections in terms of the chest or the thorax abdominal CTA. And last is the incidental PE, where we are looking at the frequency finding that actually the patient doesn't come in with any chest pain, but is doing for some follow-up CT scan for oncological diseases or a coronary CT cardiac scan. And incidentally, sometimes we miss, or the doctor will miss, there is a pulmonary embolism. And this scan will be automatically picked up by our automation platforms. So this is dedicated for scan for indication other than the suspected pulmonary embolism. And you can see here is a very typical stroke CT package flow where we will automatically receive the images from DICOM, whether this CT come from Canon or none other vendors. It can be handled within 5 to 6 minutes to give you an analysis and dispatch and run all the protocol for the CT stroke in terms of hemorrhage detections, expect scoring, large vessel occlusion, or CT perfusions. And all this will be published or it will be sent to the workstations as well as email, and you go and also opt for an option to receive the result on your mobile phone or handphone. So with that, you are able to get the result in short times like 5 to 10 minutes and make the critical decision for the stroke patient's treatment, which is time is critical. And for patients that come with an unknown onset, that is normally you can also go for MRI diffusion scan. So this is just a typical workflow where you are able to have automation platforms of our CT stroke and MR stroke to apply for different type of patients that come into your emergency department. So with that, I'd like to talk about how this operational workflow is important, because we are talking at multi-modalities, we are talking at data coming from different vendors. So with that, our healthcare IT solutions will be able to help you to accept all data for visualizations, and also we are open to all data that come from other vendors for AI-assisted data analysis. So as mentioned by Hani-san, our Managing Director, we also talk about the future of AI. Currently, we are at phase 1, where you are able to experience the AI technology to have high resolutions, noise reduction, and automatic data analysis using the application of AI deep learning. And next phase, probably in 2 to 5 years' time, we are talking about healthcare IT and in vitro healthcare solution with radiogenomics. And probably by phase 3, we are talking about ultimate resolution, smart and automated modalities in vivo functional imaging, so that we are able to deliver more precise precision medicines and a better workflow for personalized patient care. So I'm going to round off my sessions with the testimonial from our user, where on the left-hand side, you can see Professor Ohana from Strasbourg, where he used our peak, and he is saying that how peak is able to give high resolution and low noise images for the cardiac CTA, that giving him a sharper boundaries and better delineations of the calcifications. So giving him more confidence in the diagnostic report. And the center Dr. Kawano from Kyorin University, where he's using our automation platforms in terms of CT stroke. What he's mentioned is after the CT scan, everything else is automated. It will reduce the stress of technicians, it will reduce the stress of the workload, and also it will improve the decision time for stroke patients where time is critical. And last, the lady doctor from European MSK Society, Dr. Lopez, she talked about how MR AI reconstructions and compressed feeder will able to reduce the time by up to 30% without the penalty of the image quality and without reducing the time between, so that we can do more patients with the workflow and improve your operations efficiency. And thank you very much for your attention.
Thank you for the invitation to speak today to you, and my topic is current AI applications for cardiac CT that can be used to reduce radiation dose, improve spatial resolution, and improve accuracy of diagnosis. And I will also talk about comparison with photon counting CT results. In this talk, this is my conflicts of interest declaration. In this talk, I will firstly talk about methods to lower radiation dose during cardiac and body CT acquisition, how technology can help, including use of iterative reconstruction of acquired data, what is AI-assisted image reconstruction, and what is our experience and our results using this. Then I will talk about what is ultra-high resolution CT, and what is the spatial resolution of CT scanners and the factors affecting it. I will talk a bit about photon counting CT scanners and their spatial resolution, as well as using AI reconstruction software to improve spatial resolution as an alternative to buying an expensive PC-CT scanner, and what is our experience and our results using this type of software. Finally, I will talk about ultra-low dose CT lung scan screening for early detection of lung cancers and using something called a silver beam filter, and what is our experience and results and comparison with PCCT. It's important to know the main methods to reduce radiation dose during cardiac CT. The first is to use lower kVp or kV to scan, because the relationship of dose to kV is exponential. So reducing kVp, for example, from 120 kV to 100 kV reduces dose by 30 to 40%. If you reduce the kV from 100 to 80, that reduces the dose by another 30%. You can use a lower tube current, which is MAS, but the relationship is linear. So if you cut the MAS, the dose reduces, but not as much. So if you reduce it by 20%, the MAS, it can reduce the dose by 20%, but it's not an exponential relationship. The other thing that's important is reduce the scan range. I think most people always worry about collimation when they're setting up the scan, but but the collimation you should worry about is in the Z axis. That means, for example, for the neck, you don't want to you do not want to extend to the upper chest for a neck scan, or for a neck scan you really don't want to scan to the orbits unless it's absolutely necessary. The fourth thing is to use technology improvements provided by the vendors. For example, with Canon there's volume scanners and a 0.25 mm detector with scanner. There are photon counting scanners now available, and you can also use filters to remove low energy photons, something called silver beam, which I will discuss later. Then there are of course software advances. There's iterative reconstruction and artificial intelligence reconstruction using deep learning. So what is iterative reconstruction of data? This is a method of reconstruction of data to create images using complex mathematical algorithms. Most mid to high-end range CT scanners no longer use traditional filtered back projection to reconstruct the images. This needs a large amount of computing power. Look, this is the workstation we use for 3D post-processing, and this is the footprint and the size of the computer needed to do reconstruction of data. How does it reduce radiation dose? It reduces radiation dose by allowing low dose exposure scans with lower MAS. This results in noisy images that are then processed to make nice readable images. So for example, you have a low dose exposure, very low MA, you acquire the data with low signal to noise, the image is noisy, and then the reconstruction takes place in the background and you get a final image that is readable and nice. Now, let's talk a bit about AI. AI refers to the development of computer systems to perform tasks that need human intelligence. And machine learning is a subset of AI that enables computers to learn from experience. In other words, the algorithm can learn supervised or unsupervised and has ability to learn without being explicitly programmed. Deep learning is a subset of machine learning that uses neural networks for data processing. And deep learning means there are artificial neural networks that are programmed to learn from very large amounts of data and are unsupervised and is able to learn and take so-called intelligence decisions. So AICE is deep learning based reconstruction of images using a deep convolutional neural network and learns from high quality iterative reconstruction datasets which are used as the gold standard. So AICE can be used for all body CT scans, not just the heart. The input is low quality, so-called low radiation dose scans with noisy data. The model is trained and the output is high image quality. So the deep convolutional neural network is trained with thousands of examples of high quality CT exams, such as produced by model based iterative reconstruction, and AIC is tasked to reconstruct the data input and trained on this data. The deep learning reconstruction method is able to differentiate signal from noise so that the algorithm can suppress noise while enhancing signal. In other words, it increases the signal to noise ratio and contrast to noise ratio. Once the network is trained and validated in Japan, the AI reconstruction algorithm is applied to your scanner on site where it does not continue to learn. So on site you scan, the data is acquired, and the algorithm, which is already trained and offline, is used to reconstruct the data into high quality images and reduce noise within 15 to 20 seconds after scan completion. You may ask, why is the software installed offline? And this is to comply with American FDA approval requirements. So AICE is available for all body parts. You can choose if you want mild, standard or strong noise levels. So for example, with cardiac, this is example of mild noise. Mild, which means higher noise, standard, and strong, which means lower noise images. Our experience with AIC, we collected data over 3 months. We had 87 control cases which were reconstructed using iterative reconstruction, and 306 study cases that used deep learning reconstruction, or AICE. These were consecutive cases, no exclusions for high heart rates, arrhythmias, atrial fibrillation, and we examined the data for image noise, radiation dose, and image quality. And you can see our results. The signal to noise ratio was increased by 35%, in contrast to noise ratio by 40%. With radiation dose, you can see that the dose was reduced by 23%. We also saw image quality improve due to reduced noise. Here you can see that the soft plaque is better seen with AICE with sharper vessel wall images. Similarly, here's another image. You can see the lumen much better of the LAD. We also found that with stents you can see better because there is less noise in the images. Incidentally, we also found that AIC reduces noise and improves image quality in large obese patients with high heart rates. This is a patient whose heart rate was high, I think it was 90 beats per minute, and who had a high BMI. You can see we scanned with 120 kV. What about in the body? Here's an example of a 3-year-old boy with neuroblastoma. We did a CT scan of the thorax, abdomen and pelvis, and the total dose was 0.5 millisievert. There have already been publications in radiology, for example, back in 2020, showing that there was 52% radiation dose reduction using AICE compared with iterative reconstruction. In our hospitals, we operate 4 units of Aquilion 1, including 1 Prism scanner. We also have 4 units of Prime, which is a 80-row CT scanner or 160 slice, which has 4 centimeters of Z coverage. This also has AICE installed. So here's an example of a CT scan of the coronary arteries performed on the Prime 160 slice CT scanner in July this year. 63-year-old man, 55 kg. We scanned at 100 kV, and we use AICE for image reconstruction, and you can see the total radiation dose, which included the calcium score, is 3.4 millisievert, which I think is pretty good. And you can see the image quality is also pretty good. Here's an example of a CT abdomen and pelvis, also performed on the same scanner, and you can see the dose was 2.6 millisieverts. So, in conclusion, AICE deep learning reconstruction software can be used routinely during daily workload, not only for cardiac but also for body CT. It is robust, it's rapid, but huge computing power is needed, and easily used because it is on-site and offline. Deep learning reconstruction software is able to differentiate between noise and signal, so it reduces noise and increases signal, and so increases signal to noise ratio and contrast to noise ratio. Our results confirm this, because with our results we showed increased signal to noise by 35% and contrast to noise by 40% increase. There's improved image quality. It's easier to see the vessel lumen for plaque, assess for stenosis, and assess coronary stents, and it's also helpful in obese patients and high heart rates. We also reduced radiation dose by up to 23% compared to using iterative reconstruction for image reconstruction. Let's move on. The current major challenges for cardiac CT imaging include calcified plaques affecting coronary CT results can give false positive results because you overestimate stenosis, as well as false negative results because you underestimate the degree of stenosis. Coronary stents we cannot accurately assess for presence of intimal hyperplasia or in-stent restenosis in stents less than 2.5 or 3 mm in diameter, and can result also in false negative scan results, in other words, missing in-stent restenosis. The main reason for these two challenges is partial volume averaging and beam hardening artifacts coming from the calcified plaques and coronary stents, and this is all related to spatial resolution. Now, spatial resolution is determined by detector width, which is the main factor affecting Z-axis spatial resolution. But spatial resolution is almost also determined by the reconstruction algorithm used by the vendor. Many CT scan vendors claim better than 0.3 or 0.4 spatial resolution, but the question is this true in patients and not just in phantoms where they do the tests? Now, the diagnostic accuracy of coronary CTA compared to catheter angiogram or QCA is very well documented for detection of stenosis more than 50% of the coronary arteries. All the studies that have been done use a threshold of 50% diameter stenosis, and the high sensitivity of more than 95% and high negative predictive value suggests coronary CTA can be used to reliably detect and exclude a coronary stenosis of more than 50%. So we all know that coronary CTA is currently the best non-invasive test for diagnosis of coronary stenosis compared to, for example, to ECG, exercise, treadmill, stress echo, stress nuclear medicine SPECT studies. But the one issue with coronary CTA is there's a relatively low positive predictive value ranging from 75 to 89%, which means we tend to overestimate the degree of stenosis or have false positive results, and can sometimes result in patients going to the cath lab. How good is visual estimation for quantification of stenosis? This is what we use every day in real life, and it's been shown that visual estimation is as accurate as manual semi-quantitative measurements. However, the limits of agreement are wide, more than 20%, so we still use a 5-point grading scale, which is 0, 1 to 24%, 25 to 49%, 50 to 69%, 70 to 99%, and 100%. So there are all these CAD-RAD categories which I think you are all familiar with. At the same time, make sure you use the correct minimal luminal diameter and reference diameter when calculating the diameter stenosis in percent. The recommendation from this ASCII publication, which was published this year, use the average of two diameters both for the lesion and for the reference diameter. And you can also see who helped to write this paper. What about using AI to quantify stenosis? This is a study that was published last year, which is multi-center and multi-vendor. The four major CT scan brands or vendors were used. AI was used for evaluation of stenosis from the coronary CTA. The brand is called Cleary. It's been FDA approved, and you can see the computational analysis time was very fast using AI software. However, the software is not on site and the data had to be sent to the vendor. At the same time, it was found to be quite accurate, with high correlation and agreement between stenosis detected using AI software compared to coronary catheter assessment of stenosis. Here's another paper also published last year, another multi-center trial using the four major vendors. It used AI software from a company called HeartFlow. Again, it was not on site and you needed to send the data sets to the vendor. You can see the time taken for post-processing and analysis was pretty fast. However, it's important to know that the AI analysis also requires a physician or radiologist to review the images and generate the report. And again, it had high diagnostic accuracy compared to catheter angiogram. This paper was published earlier this year from a group from China, which used AI image post-processing software compared to QCT, or the semi-automated software that we all have on our workstations. It showed that the post-processing time was much faster, the workflow improves, it's easier for the radiographer. Accuracy for diagnosis is similar, but again, the software results need to be checked by a human person. So my recommendation is, if you want to buy AI software, choose your AI software vendor carefully. Buy only AI software that is CE mark or FDA approval, needs to be on site so your data sets are not sent outside your hospital, and it's better if it's cloud-based. And at the same time, you must make sure the vendor of the AI software does continuous machine learning of new data sets so that the software can be improved and upgraded. Let's move to spatial resolution. What is spatial resolution? Spatial resolution in the XY axis, which is what is called acquired resolution or in-plane resolution, is determined by detector width, detector geometry, reconstruction algorithm, X-ray tube focal spot size, as well as the field of view or the image matrix size, which is usually 512 by 512. But there is now 1024 and 1024 available, which I will discuss later. The Z-axis reconstruction in this plane, which is called through plane or reconstruction algorithm, is determined by detector row width, which was previously called effective slice thickness or slice collimation, and reconstruction algorithm. The detector row width is the main determinant of the intrinsic longitudinal resolution of the scan. So just to repeat, spatial resolution of CT is primarily determined by the detector row width, in other words, the detector element size. If you make the detector smaller, this means increased noise, and usually increased radiation dose to overcome noise. With photon counting CT, there's a possibility it may reduce radiation levels due to lower image noise and better contrast to noise ratio, but we will discuss this more later. There's also noise reduction software needed because of the increased noise. For example, you need deep learning AI assisted software. Also, data management is needed because there's increase in data set sizes of 10 to 50 times. So you need So what is ultra high resolution CT? The SCC definition is a CT scanner with detector element widths less than 0.25 along the z-axis. All the CT scanners that we are using now have detector element widths that have been unchanged since 2005. However, now there are ultra high resolution CT scanners available in clinical use. The first is the Siemens photon counting CT, which can scan in a standard mode of 0.4 mm and ultra high resolution mode of 0.2 mm collimation width. But note the Z coverage is only 4 mm or 2.4 centimeters. Canon has a CT scanner called the Precision CT with 0.5 mm detector width with 160 rows, and the Z coverage is 40 mm or 4 centimeters. There are other photon counting CT scanners in development and prototypes have been installed, but I don't expect them to be ready for use for at least another 2 years. Philips has one that has detector collimation 0.275 mm, Z coverage of 17.6 mm. Canon has one in development which has detector collimation of 0.2 mm and Z coverage of 38.4 mm. GE has one. We're not sure of the detector collimation, they haven't announced it, but it's at least less than 0.4 mm. And the difference from this and the other scanners is that it has a wide detector coverage of 8 centimeters, which may make it easier to use for cardiac scanning. Now I want to talk about our experience with using the first commercial version of a photon counting CT in Southeast Asia, which we installed in our hospital in May 2023. This was a commercial model and not a prototype, and we published our results of the first 92 patients that we scanned on this scanner. With the Siemens dual source PCCT scanner, to do cardiac scans, there are two methods. You can do a high resolution scan mode that uses 120 kV, and then the two methods of scanning are either spiral retrospective, where the scan time is quite long, or you can do sequential step and shoot, where the scan time is shorter. The other method of scanning is using quantum mode, using 0.4 mm scan collimation, but you can scan at 90 kV, and then you have the ability to do flash, sequential, or retrospective spiral scanning. The third mode, which is called quantum plus mode, was not available when we did the study. So here's an example of a large calcified in the LAD. You can see it's very nice with no blooming. Here's a stent showing nice lumen with no blooming of the stent struts. So the question is, do the newer high-resolution CT scanners make a difference for quantifying coronary stenosis? Because smaller detector size means better spatial resolution, less blooming, and less beam hardening artifacts. You can see that with the Canon scanner 0.25, the results are pretty good and the positive predictive value is pretty high. With the Siemens scanner, the positive predictive value is not as high as we would like, but this may be result of the small size of the studies, so we need more results. There are also been 3 studies where they scanned patients twice, once on a conventional scanner and once on a PCCT scanner, and they found that there was reduction in percent diameter stenosis, with many people being reclassified to lower CAD-RADS categories. Our experience with PCCT, I want to talk a bit about the radiation dose. When we scanned the patients using 0.2 mm or ultra-high resolution scan, we had to scan them with a retrospective spiral method, and you can see the dose is quite high, 7.2 millisieverts was the average. But if we scanned them on 0.4 mm with step and shoot, the dose was lower at 4.2 millisievert on average. And our radiation doses using this high resolution scan mode using 120 kV and 0.2 mm scan collimation and spiral retrospective scan is similar to other published reports. You can see here, this is our dose. This report said 13 millisieverts. This is another one said close to 14 millisieverts. This report, the dose was much lower, but they didn't do retrospective scans. They did step and shoot, but because the scan coverage is only 2.4 centimeters, you need to do multiple steps, and in real life this is not really possible. But of course the technology is new and there have been some improvements, so this is a recent scan where we can now scan using 90 kV. Previously, as I said, we could only use 120 kV, and so you can see the dose has been reduced significantly. This patient we scanned at 3.39 millisievert, and you can see the image quality, of course, is pretty good. So our experience with using PCCT scanners is image quality of coronary CTA scans performed on PCCT scanner assess both quantitative and qualitative is excellent, with almost no noise seen in the images. The problem is that artifacts can occur because of the long scan time of 8 to 12 seconds, and this is a major issue for us, where they can breathing artifacts and other artifacts. There are also different cardiac scan modes can be used on a PCCT scanner, and the radiation dose is dependent on the scan mode, and so we suggested that ultra-high resolution scan mode using 0.2 mm scan resolution should not be used for routine cases, but reserved for patients with stents and large calcified plaques. Now, what if you cannot afford to buy a PCCT scanner, because these are 3 times the cost of a Aquilian prism? Are there any alternative solutions to buying this? Well, first you can wait for the other vendors' PCCT scanners to be available and hope the price comes down, which I actually think is unlikely because of the high cost of development. You can use the other alternatives to use deep learning AI assisted reconstruction software to improve spatial resolution. So how does it work? The deep convolutional neural network is trained on datasets using high quality cardiac images. Cases are scanned on the Aquilian precision scanner, and once trained, as I said, the software is applied on site and there's no added workload to the radiograph. At the same time, because of the computer requirements, GPU chips are needed, such as from NVIDIA, and each chip or GPU chip costs $50,000 and that's why these scanners are expensive. This is our Canon Prism scanner. and we reviewed our results of 287 patients and presented in Korea at KCR last year. And you can see that signal to noise improvement was 86% compared to iterative reconstruction, and contrast to noise ratio improved by 82% compared to iterative reconstruction, and at the same time the average radiation dose was 2.7 millisievert. So here's an example. You can see plaque much better in the mid LAD with peak. Here's soft plaque with lipid-rich high-risk plaque associated, which is also better seen with peak. Here's a mixed plaque, and you can see the image quality is much better. Here's a stent, and the stent lumen is still difficult to see, but the image quality looks better. At the same time, PEAK was released in 2023, and we started using it last year in 2023. But now Canon has released a new version of PEAK which uses 1024 matrix for scan reconstruction. And this is a paper that was, or image that was published by one of the Japanese users, and you can see that on the left there's deep learning reconstruction. On the right, using 512, it was classified as a CAD-RADS 3 stenosis, and on the PEAK 1024 it's been reclassified down to a CAD-RADS 2 category stenosis because of improved spatial resolution. So in conclusion, ultra-high resolution for coronary CT, improved spatial resolution due to smaller detector width is a very much awaited for technological advance, seems to improve our results and accuracy of coronary CT and coronary stent imaging, but quantification of stenosis is still best done by visual estimation because it's the fastest and easiest and as accurate as other methods. The AI software is here and will be another tool, needs to be on site and cloud-based, and many vendors buy only CE mark or FDA approved. It improves your workflow but still needs a human person like a doctor or radiologist for quality control to review the reports. And using a dual source PCCT, there are some disadvantages for cardiac CT because of the relatively high radiation dose, so it's likely suitable for selected cases and not routine cardiac imaging, for example in patients with known large calcified plaques or patients with stents. You can use AI assisted high resolution reconstruction software called PEAK on a non-PCCT scanner as an alternative to a very expensive PCCT scanner, and it's a solution for most non-clinical, non-research university hospitals. Now I want to move on finally for the last 5 minutes to talk about low radiation dose CT lung scan for detection of early lung cancer in smokers and non-smokers. The US recommends yearly screening for lung cancer using low-dose CT for adults aged 50 to 80 for 20-year smoking history. However, low-dose CT can also be used for screening for lung cancer in non-smokers, who are usually called never smokers in the literature. It is at the moment not yet evidence-based and no data on what age to start, how often it should be done, for example, but there are more and more papers being published on Asian non-smokers showing the value of low-dose CT for early detection of lung cancer. Using deep learning reconstruction software, ultra-low dose CT scan can be performed. So just to remind you, the average effective dose of chest PA in lateral film is 0.1 millisievert. In this study, using CT scanning on a Canon scanner, the ultra low dose was 0.0 millisieverts. And this also, there's another study showing, of course, increased signal to noise and reduced noise. Silver beam is a beam shaking energy filter that uses photon attenuating properties of silver to selectively remove low energy photons from a polychromatic X-ray beam, leaving the harder energy spectrum optimized for lung scanning. It is designed to work with AICE and enables high quality no noise CT lung scans at very low radiation doses approaching conventional chest X-ray. At the moment, this is only available on the Canon Prism scanner. So here's an example of one of our patients that we scanned, same patient scanned on the left with the Aquilin 1, and you can see the effective dose is 0.97 millisievert. And here with the silver filter, you can see the dose has been reduced to 0.3 millisievert. You can see there's reduced beam artifacts at the shoulders. And here's another patient with silver beam. You can see scanned on the scanner on the left without the silver beam, and you can see the dose reduction from 0.78 millisievert to 0.32 millisievert. Again, you get sharper lung fields with lesser image noise with this silver beam filter. So we did a quick comparison with silver beam. The sample size is not very big, but you can see there's significant reduction in the dose. The average dose is 0.39 millisievert compared to 0.58 millisievert. Here's an example of a patient scanned on the Siemens dual source PCCT, and you can see, of course, the one on the left, which is scanned at 0.4 scan collimation compared to 0.5 scan collimation of the Canon. The spatial resolution image quality is much sharper because of the narrower or smaller detector width. Here's another patient. You can see the image quality of the PCCT on the scanner and the Canon on the right. Actually, both scanners still produce image quality. Now, the problem with using a PCCT scanner is that if you have a patient who cannot hold their breath because of the scan time of 2 to 3 seconds, you can do a flash mode. But when you do a flash mode, you can see the image quality is not so good on the left hand side compared to a Canon scanner, which scans in one rotation, which is, depending on scan time, depending on the type of scanner, usually around 0.35 milliseconds. Here's a patient that we scanned on the PCCT with flash, and you can see the image quality is not so good on the left, and in fact I think it missed ground glass opacity, or GGO, which is what we worry about as an early lung cancer, because it can't be seen because of the image quality. So we recently compared our radiation doses using silver filter in March, and you can see that with the Siemens scanner, this is our average dose, and with our CT scanner without the silver filter, it's still pretty good, and with the silver filter the dose is reduced. Actually, Siemens uses a tin filter, so this is with the tin filter and this is with the silver filter, so you can see the dose is comparable and in fact maybe even lower.
Also, you show us for compare with the photon counting with some AI using application for Canon CT scan prime system. And now we move to the question. Kính thưa các quý đại biểu, như vậy chúng ta đã nghe hai cái báo cáo sáng nay về ứng dụng AI trong lĩnh vực chẩn đoán hình ảnh, và đặc biệt là cái hệ thống thiết bị của Canon. Chúng ta thấy là những cái ứng dụng có 3 cái điểm chính. Một là cái nâng cao cái chất lượng. Ở đây sử dụng AI để chúng ta tái tạo cũng như là cái đưa ra cái chất lượng hình ảnh nó tốt nhất, giảm thiểu các cái nhiễu và tăng cái tín hiệu cũng như là cái tương phản. Cái thứ hai là cái tập trung vào cái workflow. Ở đây là các hệ thống AI tự động, như là các cái nhận định tự động các cấu trúc giải phẫu, chụp tự động, cũng như là khi chúng ta các cái lát cắt cũng như là định vị giải phẫu tim tự động chụp theo các cái vị trí các buồng tim chẳng hạn, thì như vậy cái workflow nó nhanh hơn. Cái thứ ba là liên quan đến ứng dụng trong cái phân tích, diễn giải, đọc kết quả. Ở đây là có các cái phần mềm như là các cái phần mềm về đột quỵ. Chúng ta sẽ cho các hình ảnh mức độ tổn thương cũng như là tưới máu cũng như là các vị trí mạch tắc. Các cái phần mềm AI tự động đánh giá cho bóc tách động mạch cũng như là các cái tắc, các cái động mạch phổi, cũng như là các cái tổn thương, phát hiện các cái tổn thương khác trong ung thư, trong ung bướu theo dõi. Thì đó là những cái ứng dụng trên cắt lớp vi tính, siêu âm, cổng từ cũng như là chụp mạch từ các cái phần 3 cái lĩnh vực chính như vậy. Và chúng ta đã nghe bác sĩ John Ho là một chuyên gia của Singapore, giám đốc cái hiệp hội điện quang Singapore, chuyên gia về tim mạch. Chúng ta thấy là các cái ứng dụng trong cái AI, chúng ta sẽ cho được cái chất lượng hình ảnh nó tối ưu, giảm được cái các cái nhiễu, tăng cái cường độ tương phản, và chúng ta cho chất lượng hình ảnh của mạch vành nó rất là tốt, và tăng đến 30 đến 40% các cái tương phản hình ảnh, và giảm cái liều tia xuống còn có 23% so với lại cũ. Thì đấy là những cái điểm rất là quý, và đặc biệt là ứng dụng cái AI trong việc tái tạo các cái hình ảnh mạch vành. Và hiện nay thì chúng ta thấy là hai cái trở ngại chính trong cái chụp mạch vành, đó là cái vôi hóa cái điểm canxi score ấy, rất lớn. Và hiện nay ví dụ trên 1000 chúng ta vẫn sử dụng các cái máy chất lượng tốt, là ví dụ như là photon counting hoặc là cái máy cắt lớp vi tính mà sử dụng cái AI như Canon đã báo cáo ở đây, thì chúng ta thấy là có thể giải pháp những cái điểm canxi score lớn. Và thứ hai là những cái kích thước nó nhỏ trong stent, tổn thương trong stent đường kính dưới 2.5 mm, để chúng ta xem là trong đó nó có tăng sinh nội mạch tắc trong stent hoặc huyết khối. Thì những cái điểm nhỏ đấy là cái hạn chế chính của các cắt lớp vi tính các thế hệ bây giờ, làm cho nó đánh giá quá mức hoặc là đánh giá không đánh giá được. Thì đây là những cái giải pháp. Và đồng thời chúng ta thấy là một số các cái ứng dụng khác trong các phát hiện các cái tổn thương khác. Thì chúng ta đã nghe hai cái báo cáo, và chúng ta thấy là các cái ứng dụng AI hiện nay rất là tốt trong các cái xử lý workflow, các cái công việc hàng ngày, cũng như là trong các cái bản report mà chúng ta có, làm cho cái dữ liệu hình ảnh cũng như là các cái giá trị. Và đặc biệt AI này thì bác sĩ John Ho cũng khuyến cáo chúng ta là sử dụng những cái AI nhưng mà được chấp thuận bởi FDA hoặc là CE châu Âu. Và đồng thời khi mà những cái ứng dụng này thì cái quá trình học chúng ta vẫn, người ta sẽ chuyển tải các dữ liệu thành các big data, và các cái dữ liệu đó người ta sẽ tiếp tục học sâu, và chúng ta sẽ cải thiện được cái AI chúng ta đã có. Tôi sử dụng như vậy thì được khuyến cáo là khi chúng ta sử dụng AI như vậy, và cái kết quả AI này nó rất là chính xác so với lại cái kết quả mà chúng ta đang đọc bây giờ. Thì đây là những cái mà rất là hứa hẹn, chúng ta thấy là ứng dụng rất là nhiều. Sau đây chúng ta sẽ chuyển sang các cái thảo luận và câu hỏi. Now we move to question and comment from the floor and audience from the online. So for the first question, I like ask the Dr. Lutek what about the when you talk about the AI from the Canon system, this of the AI is approved by FDA or CE?
Yes, for the AI technology that is integrated to the Canon systems, we already have applied for FDA, and all this has been approved and launched in the RSNA. So like the technology that Dr. John Ho has mentioned, the peak high resolution cardiac images and body images of 1024, it was already approved by FDA and CE marking.
Cái câu hỏi đầu tiên này tôi cũng hỏi ông Lưu Tech Huyat là cái phần mềm AI mà ông giới thiệu cho cái của hệ thống Canon, thì các cái hệ thống AI này đã được chấp thuận bởi FDA, và mới đây nhất là cái phần mềm PIC liên quan đến cái version 1024 ấy thì vừa mới được chấp thuận của cái FDA và liên quan đến cái áp dụng cho cái phần tim mạch vành.
Vâng, thì trước tiên thì cũng rất là cảm ơn hai báo cáo viên có cái bài báo cáo rất là thú vị và hay, đặc biệt là trong AI, trong cái lĩnh vực mà chẩn đoán hình ảnh nói chung và trong cái tim mạch nói riêng. Thế thì nhân cái dịp này thì cũng xin phép có một cái câu hỏi chung cho báo cáo viên là cái việc mà ứng dụng cái AI ở trong cái chẩn đoán hình ảnh và ở của Canon, thì một số ứng dụng thì chúng ta thấy rằng là tích hợp trên hệ thống Canon, và một số ứng dụng thì có thể ứng dụng bên thứ ba hay không. Và câu hỏi chung với cả giáo sư với Dr. John Ho là cái việc mà ứng dụng cái AI đấy đặc biệt trong hình ảnh tim mạch thì nó có cái ý nghĩa vì trước cái thời điểm photo thì bên chỗ Dr. John Ho đã ở bệnh viện Mount Elizabeth đã sử dụng cái đấy rồi, và cái việc mà ứng dụng khó khăn như phó sư Lưu nói với cái điểm phôi hóa hoặc là những cái instant ấy, thì cái đấy thì nó có ưu điểm gì trong cái việc mà nó cái việc ứng dụng trong thực hành lâm sàng của bên chỗ Dr. John Ho? Now I have a same question for two speakers. For first question is about Mr. Kevin Low. So I would like to ask, as we have so many AI applications, so I would like to ask that from your company, is any kind of third-party AI from Canon, and that we can apply for other vendors? As we know that BACMA is very busy and the workflow is very high demand, so we need a very good image qualities and very quick scan time, can reduce the scan time. So with the solution from Canon right now, you can have a kind of third party for the others vendors modalities. And my second question to Dr. John Ho. Dr. John Ho, can you see us?
Yes.
Yes. Yes, sir. So one of the pity is that you could not join us here today is on site. So I know that you already have a surgery. So but very nice presentation. And I have a question about before the photon counting. So you already use a picker. So what is the most benefit for the picker if you use this for the reduce artifact from the heavy calcifications and instant stenosis? And is there any kind of advantage with the picker 1024 in comparison with photon counting right now you have? Because I know that you have both system in your hospital, Canon and photon counting. Thank you.
We have peak and it's automatic. So every case that is scanned on the Aquilian prism is automatically reconstructed using peak. So we just use it for every case. So we don't choose. And as I said earlier, it's very fast. Maybe it takes 20 seconds after you scan the patient to get the image out, to look at it. We don't have 1024 matrix at the moment. We're still using 512. But of course, the image quality is much better, so it makes it easier to read the images. The other thing is many people ask us when they come and visit, how do we decide which cardiac, I'm talking about cardiac patients, to scan, how do we decide whether to scan on the Siemens PCCT or to use the Canon? And to tell you the truth, we always prefer to use the Canon because for radiographer, it's much easier to set up. It's not so complicated. And now I heard Ken say there's AI software to help radiographer do the protocol. Well, we don't have it, but we are waiting for it because it sounds much easier. But even without the AI, it's much easier to scan for a radiographer. Secondly, many of our patients have atrial fibrillation or ectopic or high heart rate. And we find that the Siemens scanner, because of the way it scans, there are a lot of artifacts. So we always do all those patients on the Canon scanner. So the only patients that we scan on the Siemens is if we know they have a lot of calcification or we know they have stents and if they have a low heart rate. Because if there's the other issue, as I mentioned, is the scan time. With a volume scanner like the Siemens, the scan time is very fast, right? Less than, well, depends what you call it, depends your scan rotation, but half a rotation, 0.35 milliseconds or 0.27 milliseconds. But the Siemens scanner, because it does retrospective gating for cardiac scan, we're talking about cardiac scan, it takes 6 to 12 seconds. So we have a lot of problems. Patients breathe or the images are no good because of that scan time. So even with calcified plaques and stents, we are still very careful which ones we scan, which patients. If we think they cannot hold their breath for 12 seconds, we will scan on the Canon. I hope that answers your question. The other comment I want to make, which I found out today listening to Mr. Ken, is that AICE or AI software is usually with most vendors, that means not other brands of scanners, is usually only available on medium or high-end, very expensive scanners. I did not realize that with Canon, it's available on a 16-slice scanner. So that is actually very amazing because, as I mentioned, AI software is very expensive because of the computer you need to use. So I think that's something I never realized because we don't have 16 slice, but we only have 80 slice. But if you have to buy 16 slice, well, then I think the decision is easy.
Vâng, thank you, Dr. John Ho. It's a very clear answer. So I make a brief translation to our audience. Thì cái câu hỏi được giáo sư John Ho vừa trả lời là cái việc mà chúng ta sử dụng cái công nghệ AI ấy, đặc biệt là cho các hệ thống máy. Thì đây thì bên chỗ bệnh viện Mount Elizabeth cho Dr. John Ho thì có kinh nghiệm sử dụng cái hệ thống Canon từ lâu rồi. Và hiện tại thì chưa có cái hệ thống ICE mới nhé, 1024 mà chỉ là 512 thôi. Tuy nhiên chất lượng hình ảnh cũng khá tốt và họ thường sử dụng cho cái nhóm mà bệnh nhân mà không phối hợp nín thở hoặc nhịp tim không đều. Và chỉ trừ thì hiện tại thì bên đấy cũng lắp cái hệ thống photon counting mới thì thường sẽ ứng dụng cho cái nhóm mà nhịp tim thấp và có cái điểm vô hóa rất là cao. Đấy là cái sự khác biệt. Và đối với cả hệ thống AI mà pick ở trên hệ thống Canon của bên chỗ Dr. John Ho sử dụng, cái thời gian chụp cũng như thời gian tái tạo xử lý rất là nhanh và rất là dễ dàng cho cả kỹ thuật viên, và thường thì ứng dụng trong các hệ thống mà các lớp vi tính cao cấp. Thế còn lại đối với cả các cái hệ thống mà kinh nghiệm, một cái nữa là liên quan đến cái liều tia nữa thì cái việc mà sử dụng cái hệ thống Canon thì đối với cả cái theo kinh nghiệm của Dr. John Ho thì cái việc đấy cũng giảm thiểu được cái liều nhiễu ảnh và cái nhịp thở cho bệnh nhân, đặc biệt những cái nhóm bệnh nhân mà khó nín thở. Ok, thank you.
Okay, thank you, Dr. Chang, for the questions. I think this is a questions that I've been asked many times, whether our AI are able to accept images or data from other scanners. So as we know, the principle of deep learning are training pairs. Training pairs means we use input and output to compare, and then this AI algorithm pick up the difference and train. So for Canon AI, especially in the modalities like CT, ultrasound, MR, and even the angio, we use the data from Canon to train. So with that, this is optimized for Canon data. And that's why it's only applicable for Canon data. And I know that in the market out there, there may be third-party solution that they say that, oh, for the AI solutions, it's applicable to all vendors, whether they don't care is Canon, Philips, or such. But we may not know what type of training pair that are being used. So it is very important for FDA AI solutions because we are able to verify the data and the AI algorithm will give you the optimized result and the optimized image quality. On the other hand, our automation platform, which is the AI reporting or AI insight for CT stroke, MR stroke, and pulmonary embolizations, aorta dissections, we are being trained. We use it to train not just the Canon data, but the GE data, the Philips data, and other data. So with that, that is the only solution in Canon that is allowed to be applied to third party, like for other vendors. So that is the only solution that we have FDA approved that are able to use other vendors. So for that, I hope that answers your questions why we are not accepting other data, because training pair is important, optimized result is important, and FDA approved is important.
Okay, thank you, Peter Kevin. Xin phép dịch lại cái câu trả lời về ở đây thì chúng ta thấy rằng là Canon thì ưu tiên phát triển các cái hệ thống sinh thái của Canon trước, và họ sẽ phát triển các phần mềm AI bằng các cái data xuất phát từ các hệ thống máy của Canon. Thế do đó mà một số cái phần mềm AI trí tuệ nhân tạo chỉ sẽ tích hợp trên hệ thống máy của Canon thôi. Tuy nhiên thì trong Canon thì họ cũng sử dụng một số những cái phần mềm trí tuệ nhân tạo cho cả các cái hệ thống khác. Ví dụ như là trong bài báo cáo chúng ta thấy rằng là về đột quỵ, về phát hiện các cái bóc tách động mạch chủ, hoặc là những cái phát hiện những nhồi máu phổi, thì Canon cũng sẽ có thể sử dụng các cái data dữ liệu từ các bên hãng khác, ví dụ như Siemens, GE hoặc là Philips vân vân. Tuy nhiên thì chúng ta thấy rằng là cái quá trình mà đào tạo hay là trí tuệ nhân tạo học máy thì cần phải có cái nguồn dữ liệu để cho máy nó học được. Thế do đó mà cái bước phát triển ban đầu thì họ sử dụng cái data của Canon, do đó mà để nó sẽ tối ưu hóa được cái vai trò của trí tuệ nhân tạo. Và cái hệ thống này thì cũng được mà FDA và hoặc là CE đã được công nhận. So maybe I have a next question. Is it possible to upgrade? Is it easier to upgrade or flexible or modify the AI if we use the Canon system based on the data from hospital? For example, from Dr. John Ho, if he used the Canon system for a long time, so when can we make it precise or modify to optimize with the data from the hospital, from the clinical or one by one? For example, like mine or Mount Elizabeth, is it different? Maybe we have a different style of data. So can you modify a little bit later?
Okay, to answer that questions, I think this bring up to one of the topic also bring up by Dr. John Ho, because the AI algorithm only factory trained with the data that we have. So when it's applied on site to the hospital, it does not train anymore. The reason why is we need to control the training, because some data might affect the algorithms. And for all FDA approved AI, it has to be a supervised learning. That means the input and output need to be controlled. So for that is for now. So we do not know how the AI will evolve. I think it's very fast. And we also do not know how the AI committees in the FDA or radiology is going to be changing their regulations. But as of now, no training at site for changing the algorithm. Maybe Dr. John Ho has something to add on that.
I mean, I only made that comment because, of course, we have a lot of data that we would like to feed back to Canon, and I think we are feeding back some. But as I mentioned, it's a FDA requirement that you cannot train the data at your site. But we hope that whatever data that we are sending back to Japan is actually being used. Of course, we don't know if Canon is using it.
Yes, we are looking at your data.
Vâng, thank you. Như vậy là cái câu hỏi rất là nhanh thôi, tại vì về vấn đề cái data ở đây thì chúng ta biết rằng là AI nó liên quan đến dữ liệu từ đầu vào. Thế thì cái training mà hệ thống học máy hay AI thì họ phải sử dụng một cái kiểm soát cái dữ liệu đầu vào. Thế do đó mà dữ liệu đầu vào nó phải hết sức là ổn định. Thế do đó mà cái câu hỏi là nếu mà liệu chúng ta có thể cá thể hóa hay là chúng ta có thể thay đổi theo cái dữ liệu của từng bệnh viện hay không thì hiện tại thì chưa thể được, mà chủ yếu rằng là theo cái luật rất là chặt chẽ của FBA chẳng hạn thì chúng ta phải kiểm soát cái dữ liệu vào cũng như kiểm soát dữ liệu ra. Thế do đó mà các cái đơn vị phát triển AI thì hầu hết là họ đều phải kiểm soát được cái nguồn dữ liệu đầu vào, giống như Canon như thế. Thì cả câu trả lời của ông Ken Vilo và Dr. John Ho thì cho chúng ta thấy rằng là cái việc kiểm soát dữ liệu và training cái AI thì hiện tại chưa thể nào áp dụng rộng rãi thay đổi cái thuật toán được, mà chúng ta sử dụng là vẫn phải áp dụng theo đúng cái thuật toán của nhà sản xuất. Vâng, xin mời phó sư Lưu.
So we have two questions from the attendee, and Dr. John Ho, can you see the question on the screen? And the first question is with the 0.24 second for rotation from Canon system, how many heart rates the system can scan within 1 beat, please?
Oh, I can't remember. I think it's around 70 or 75. Then sometimes it needs 2 heartbeats, but the software has improved a lot. So actually, even with high heart rates, most of the time it's 1 heartbeat. It previously, a few years ago, you have to do 2 or 3 heartbeats, but we hardly ever do 2 heartbeats now. So, but I cannot remember the heart rate. But basically, 2 heartbeats means higher radiation to the patient. So obviously, the more patients with high heart rates that you can scan with 1 heartbeat, the lower the radiation. I hope that answers your question.
Vâng, có cái câu hỏi đầu tiên của online, của đại biểu online, chúng ta thấy rằng là cái câu hỏi về cái việc mà chúng ta sử dụng cái nhịp tim nào đối với cả hệ thống Canon, bởi vì chúng ta thấy độ phân giải thời gian rất là cao, 0.24 giây. Thế thì thông thường thì chúng ta chỉ cần, theo câu trả lời của Dr. John Ho, chúng ta chỉ cần chụp trong khoảng độ một chu chuyển tim thôi, vì cái hệ thống này có cái độ rộng detector khá tốt. Thế tuy nhiên thì nếu mà trong trường hợp mà câu hỏi về liên quan đến cái nhịp tim thì Dr. John Ho cũng không nhớ rõ. Và thường thì chỉ quan điểm rằng là nếu đa số các cái trường hợp thì đều chỉ chụp trong một chu chuyển tim thôi, còn nếu trong trường hợp mà chúng ta phải chụp tới 2 chu chuyển tim thì lúc đấy là nhịp tim thường cao và đầu tia thì sẽ tăng lên cho bệnh nhân.
So may I add on with the 0.24 second? Actually, now we can achieve for high heart rate that is not more than 100 beats per second per minute. We can acquire in a 1 heartbeat scan, 1 rotation.
Và chúng ta có thêm một cái câu hỗ trợ từ Mr. Kevin là cái hiện tại nhà sản xuất thì với cái nhịp tim dưới 100 chu kỳ 1 phút thì chúng ta vẫn có thể chụp được với cái hệ thống Canon này. Thank you.
And the second question for Dr. John Ho is as the coverage of photon counting of Siemens is only 2.4 Siemens cm of the ultra high resolution mode. So how many bits the system can scan for the whole heart image? It's very careful to manage the heart rate. Please.
Yes, that's why, and that's why you have to have very low heart rate. Otherwise, you get a lot of artifacts. This is like, when we used to scan 10 years ago, before volume scanning, we have to do this spiral with step and shoot. The other, as I said, with the Siemens, you can scan at 0.2 mm resolution, but the Z coverage is only 2.4 centimeters. If you go to 0.4 mm, the Z coverage, I think, is 58 mm. So you still, it's not enough. Okay. So we still have artifacts on the pictures. Most scans, actually, we do have artifacts, but you can still read the scan. It's just that if you try to make a picture to show your patient or show the cardiologist, the picture is not nice because of the step artifact or because of the contrast difference. So this is the other problem that we have. The other thing I want to say is that actually the Siemens workstation for post-processing is maybe designed for cardiologists, not so much for radiologists. So we actually post-process all our images on Vitria, because Vitria, which is now owned by Canon, can post-process for any brand. So like it can process cardiac images for Philips, Siemens, and that's what we use. We don't use the Siemens post-processing software for cardiac.
Và có một câu hỏi nữa liên quan đến cái so sánh với cái kinh nghiệm sử dụng photon counting, bởi vì chúng ta thấy rằng là cái photon counting thì cái độ phân giải, đặc biệt khi cắt ở chế độ phân giải siêu cao ấy, thì chúng ta thấy rằng là cái tiêu điểm cái trục thứ ba, trục Z ấy, thì nó khoảng là 2.4 cm. Thế thì cái này thì nó không giống như là quét khối thể tích tim như là hệ thống của Canon. Thế do đó mà theo Dr. John Ho thì chúng ta vẫn phải sử dụng, vẫn phải quan tâm nhịp tim, và chúng ta thường sẽ phải dùng đối với cả nhịp tim nó vừa phải thôi. Và vẫn có xuất hiện những cái nhiễu ảnh trong quá trình chụp, bởi vì đây là chụp theo chế độ mà từng bước một và từng đoạn một, sau đó chúng ta tái tạo ảnh và ghép lại với nhau. Thì do đó mà trong thực hành lâm sàng thì Dr. John Ho cũng thấy rằng là cái hệ thống mà trạm làm việc của Siemens thì thường là thiết kế ưu tiên đối với bác sĩ tim mạch. Thế còn lại hệ thống mà trạm làm việc khác của đặc biệt của Canon thì có thể sử dụng cho bác sĩ chẩn đoán hình ảnh, và chúng ta có thể tái tạo nhiều ảnh và tái tạo theo cái mong muốn của chúng ta, chứ không phụ thuộc vào cái việc chụp và tái tạo. Đấy là một cái ưu điểm. Vâng. And maybe follow this question. I would like to ask Dr. John Ho, do you think AI from photon counting will solve this problem when we scan the step and shoot, light motion correction and contrast materials?
Actually, they have come up with some new software. It's called Z something, which we have not got, is to get rid of some of this artifact. But we are, of course, talking about photon counting PCCD for cardiac scanning. For body scanning, because it can scan at 0.4 mm compared to Canon, which is 0.5 mm. Of course, the images of the bones and the lungs are slightly better because of the difference in spatial resolution. Of course, the main difference is it costs 3 times more than the most expensive Canon scanner. So you can buy 10 ordinary scanners for 1 PCCT. So unless you have a lot of money or someone donate to you, I think it's very difficult to buy one of these scanners for a busy hospital. If you have 10 CT scanners, maybe you can buy 1 PCCT.
Và cũng nhân cái câu hỏi này thì vừa thực tế rằng là cũng hỏi Dr. John Ho luôn, vì các hãng sản xuất bây giờ cũng đưa ra các cái phần mềm trí tuệ nhân tạo để giải quyết được cái nhiễu ảnh do chuyển động hoặc nhiễu ảnh do tương phản. Thế thì cái này thì cũng Dr. John Ho cũng trả lời về cái việc mà hiệu quả và chi phí thôi. Tất nhiên là cái hệ thống photon counting hiện tại đang giá rất là cao so với cả các hệ thống cao cấp nhất của Canon. Thì nó tùy thuộc vào từng quan điểm, từng bệnh viện thôi, còn chúng ta có thể sử dụng và đầu tư. Vâng, xin mời phó sư Liễu.
Vâng, các quý đại biểu của chúng ta có câu hỏi gì thêm không ạ? Nếu không có thì chúng ta đã có một cái báo cáo sáng nay, chúng ta đã có một cách nhìn tổng quan về AI ứng dụng trong chuyên ngành chẩn đoán hình ảnh và các cái giải pháp công nghệ và các cái phần mềm, và chúng ta thấy là rất là hữu ích trong cái việc là tăng cường các cái chất lượng hình ảnh, cũng như là cái quá trình công việc nó thuận tiện hơn, không chỉ cho kỹ thuật viên mà cũng như là chính xác hơn cho cái quá trình diễn giải, cũng như là trong cái công việc hàng ngày và trong các cái báo cáo. Và đặc biệt là các cái công nghệ mới hiện nay chúng ta thấy là vượt qua các cái thách thức, sử dụng các cái công nghệ trí tuệ nhân tạo cũng như là các cái công nghệ của thiết bị hình ảnh, chúng ta đã làm cho cái hình ảnh nó chi tiết hơn, đặc biệt là những kích thước nhỏ hoặc là những cái giới hạn mà trước đây những cái nhiễu ảnh do các cái vôi hóa nó gây ra cái chẩn đoán nó kém chính xác. Và cái quá trình ta thấy là cái AI nó sẽ ngày càng hỗ trợ cũng như là trong cái công việc hàng ngày chúng ta rất là cần thiết. Để tôi nghĩ là chúng ta sau buổi hôm nay chúng ta sẽ có thêm được rất nhiều kiến thức về AI trong lĩnh vực chẩn đoán hình ảnh, và chúng ta sẽ áp dụng được trong cái thời gian tới ấy. Và lần nữa xin cảm ơn các diễn giả cũng như là các quý đại biểu. Thank you very much for Dr. Junho and for give excellent lecture and give us for discussion with considering about the AI and also the high technology for the CT scanner for coronary system. And thank you very much for joining us. And thank you for all the speaker and audience for participating of this congress. And thank you.